I'm Austin Mondloch. I'm the second year pharmacy clinical fellow with Aegis. So today we'll be talking about managing neonatal abstinence syndrome and talk about screening and then medication monitoring that goes along with it. Just as a quick side note, this presentation is for informational purposes only. And in terms of objectives, I'll go ahead and read these off. So we'll want everyone to be able to understand the impact of prenatal substances use on neonatal outcomes and the development of neonatal abstinence syndrome, which is typically abbreviated NAS. We want everyone to recognize the importance of urine drug screenings during pregnancy as a tool for detecting substance use and assessing the risk of NAS. We'll look at examining the barriers and challenges faced by pregnant women with opioid use disorder and accessing prenatal care, and also understanding the significance of providing comprehensive addiction treatment services. And then finally, assessing the significance of a patient centered and non judgmental approach in providing healthcare to pregnant women with OUD or opioid use disorder, as mentioned in guidelines. So, for neonatal abstinence syndrome, who is this affecting? This is affecting the infants that are born once they've been essentially exposed to some sort of opioid or pain medication that's taken by the mother. So in the United States, roughly one baby is diagnosed with NAS every 24 minutes, which then gives us more than 59 babies who are diagnosed every day. This percentage grew by 82% between 2010 and 2017, and this is based on national data. And up to 80% of opioid exposed infants then develop neonatal abstinence syndrome. So when a pregnant woman uses opioids, there could be a number of reasons, but overall, once the pregnant woman uses opioids, that drug gets to the baby by passing through the placenta, gets into the baby's bloodstream, and this can then cause physical dependence. Now, I think a word that may trip people up a little bit is the word abstinence. It's not like this baby is choosing not to take this drug or this opioid anymore. It's truly that the baby no longer has it's no longer available to that baby. So it's, I think a key word is withdrawal. So the baby's going through withdrawal syndromes. So it's typically abbreviated as NOWS, or NAS may also be referred to as NOWS, and that stands for neonatal opioid withdrawal syndrome. And once that drug is no longer available to the baby, then typically that baby experiences these withdrawal type symptoms, often within 72 hours of birth. So, like I said before, there may be various reasons as to why the pregnant woman is using or taking opioids. There could be legitimate reasons and causes as to why the mother is ingesting these opioids. It could be from like an injury, or they may be taking it due to some sort of pain, such as back or pelvic pain. But also often, potentially, the woman may be suffering from some sort of disorder, such as opioid use disorder, and the mother may not be ready to quit, um, or they are concerned about potential withdrawal symptoms that they themselves may experience if they try to get off the opioid, and those withdrawal symptoms could maybe affect the baby in some sort of way. So, there could be legitimate reasons, or there could be, reasons such as like an opioid use disorder as to why the mother is taking opioids, and then how that's then getting into the baby system. So, in terms of kind of like a timeline, or kind of various factors and reasons that occur as to why NAS may be occurring and what's happening here. So, a patient may be suffering from OUD. They may be in childbearing age. There may be limited access to birth control, and then an unintended pregnancy may occur. That pregnant woman may still be suffering from opioid use disorder. There may be minimal access to maternal care or prenatal care. And then, in turn, the newborn is delivered and potentially diagnosed with NAS. And then, once that baby is diagnosed with NAS, there's actually an increased chance of then that child developing opioid use disorder. And then we kind of see this snowball cycle type effect that we can see on the screen. In terms of symptoms, these are typical of withdrawal symptoms. So these are specifically what we may see in an infant. So tremors, difficulty sleeping, nausea, vomiting, diarrhea. And some of that diarrhea may lead to dehydration. That can cause even downward effects, twitching, tachypnea, and then also seizures, which seizures are most likely to occur in those born to like methadone users. But yeah, these are just some examples of those NAS type symptoms we may see in the child. In terms of treatment, NAS is a treatable situation. Overall, the mother should be examined in terms of what's the best possible outcome. What kind of alternatives can the mother receive if they need opioids for pain, or they are going through some sort of opioid use disorder. Overall, in order to help the soon to be child, I think we also need to focus on helping the mother as well. It needs to be kind of a dual thing. So we should recommend medication assistance treatments to these women suffering from opioid use disorder. That's commonly abbreviated as MAT. Some of those medications that are involved in MAT, especially with opioid use disorder, are medications like buprenorphine and methadone, and then also therapy should play a role as well. So cognitive behavioral therapy should also be offered to this woman as well. Cognitive behavioral therapy is often abbreviated CBT. So, in terms of the severity of the NAS, it should be known that the expression and severity of NAS is not correlated with the exact dose or medication the mother is exposed to. This is important to say because sometimes the woman may either stop taking the medication, or more often than not they'll reduce their dose in hopes of trying to reduce how sick or how severe the NAS of the baby, how it will occur in the end. So again, like I said, it's not correlated. The severity is not correlated with the dose. So even if the woman stops taking as much or reduces her dose, it's really not going to make much of a difference, and it actually may cause her to experience withdrawal. So there's really no point in reducing the dose. But again, some sort of medication assisted treatment or therapy should kind of go into play in order to help the woman, and in turn help the baby as well. But in terms of managing the symptoms of NAS, like I said, it is treatable. So we can provide supportive care, some non-pharmacological treatments such as rooming in. In terms of pharmacological options for the baby, in terms of treating their NAS, we can give the baby liquid oral morphine and then also liquid oral methadone to help with their symptoms. And in severe cases, as an adjuvant, we can also provide clonidine or phenobarbital, or the provider can also provide clonidine or phenobarbital to the baby as they're suffering from NAS. So these are some of the treatment options. Like I said, it is a treatable condition. In terms of prenatal care, going back to the mother, so a lot of times pregnant women with opioid use disorder sometimes receive insufficient or no prenatal care, and these reasons may include a lack of awareness of the pregnancy, fear of legal repercussions, financial constraints, especially if they have multiple kids, and some kids need to go to daycare, and it's hard to find the time, transportation, and then also concerns about losing custody as well. Overall, it does appear that women with OUD may be motivated to seek therapy to kind of help the well-being of their child. And pregnancy can also be seen as kind of a transformative period, with the potential for some positive change and like a significant shift in their lives once they realize that what they're doing to themselves not only affects themselves but also can affect their newborn child as well, with NAS potentially occurring in their child because of what they're dealing with. So, in terms of drug testing, especially urine drug screens, can be a really powerful tool in terms of figuring out exactly what the mother is taking and ingesting. In terms of self-reporting, there definitely can be some bias. It can be, in terms of the patient actually telling the provider what they're taking. They may be hesitant due to fear of social and legal repercussions. So that way, some sort of urine drug screening or drug testing can be utilized to figure out exactly what's in the patient's system. And typically, urine drug screens utilize immunoassay techniques, which are known as presumptive tests, which I'll talk a little bit more on this slide. So, presumptive testing includes immunoassays. So, immunoassays, just based on how they work, they may cause false positive or false negative results just based on the cross reactivity of the amino and the substances that are found in the patient's urine. So, a lot of times with false positives, it may get the woman in trouble if it thinks if the test is showing she's positive for one thing when she really isn't. So that's an example of a false positive. But then even a false negative, if the patient's supposed to be compliant on a medication and it's not showing up as a negative or a false negative, that could also potentially get the woman into trouble as well. And then even depending on the amino assay, the degree of the cross reactivity may change. So that's why presumptive testing in a perfect world really should go on to then confirmatory or definitive testing. So again, so with presumptive testing, which includes amino assays, they may be incorrectly interpreted, and that could lead to some harmful effects. Harmful effects such as less patient care, less trust between the patient and the provider, and these could be the results from these false positive or false negative results. And even if contested in court, results from the presumptive test may not hold up. So that's why confirmatory testing, such as definitive testing, which uses machines such as mass spectrometry, liquid and gas chromatography machines, those should then be utilized to confirm or definitively say what's in the patient's system. So SAMHSA recognizes that failure to perform confirmatory or definitive testing or urine testing, to be specific, can be disastrous as it may provide false positive findings, which may result in the loss of child custody and, in some cases, legal prosecution. And then again, even by the American College of Obstetricians and Gynecologists, urges firmly that medical professionals should not let the interpretation of a positive urine drug screen prevent or impede the provision of essential medical care to pregnant patients. So overall, I think we need to foster a compassionate relationship between the patient and the providers. Providers can use these drug screens and the drug monitoring capability to provide counseling and support for the patients. Overall, then they can track treatment effectiveness and hopefully to prevent the development of NAS. So this can kind of be a step one in figuring out what the patient is dealing with and struggling with, and then from there how we then can help the patient. And by helping the patient, the mother, we're really helping two people because we're helping the soon to be born uh, infant as well. So, like I said, presumptive testing has a place and kind of give us a start, but then definitive or confirmatory testing should then be put in place in order to help the mother as best as possible, especially with any sort of legal ramifications. As I mentioned before, sometimes that prevents these women from seeking help in the first place. But overall, drug monitoring can kind of help, again, foster that relationship in terms of managing the opioid usage of the pregnant woman in order to figure out exactly what's going on. But again, a positive urine test should never be used as a justification to withhold or withdraw any sort of prenatal care, because not only are you affecting the woman, but then you're going to affect that soon to be newborn baby as well. But so overall, this situation should be approached with empathy, devoid of prejudice, and we can use this monitoring and this knowledge to then not only help the mother, but help the baby as well. And we can use it to foster communications and make sure that the mother's receiving the treatment that she needs and deserves, and as well can hopefully prevent any negative effects going forward in that soon to be born child as well. But I hit on a lot of different things. Here is me in that bottom left, and then I do have some references, and I would be happy to answer any questions that anybody has.